see the people?
They should show up in our participants right away
Okay.
here.
Okay.
Yeah. There we go. Some people are joining us. We'll just give it a moment, make sure everyone joins. Okay. Number is still rising, so that's great. All right, well, I will get started with a little bit of an introduction. So welcome everyone to the newly diagnosed with Parkinson's, when and what treatment options are available webinar with Dr. Suchowersky. My name is Ashley Plouffe and I will be moderating this webinar. If you have any questions during the webinar, please submit them in the chat below. At the bottom of your screen, there's a little blurb chat icon. It'll appear on the right-hand side of your screen and you can type out your questions there and we'll get them answered for you. Just a disclaimer, this webinar will be recorded and all the information is provided by Parkinson Association and the featured speaker. It's furnished strictly for educational and entertainment purposes. This service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, or care of your physician. General questions about symptoms, treatments, and available medications, complementary and alternative healthcare therapies, and current research will be fielded. So Dr. Suchowersky received her undergraduate and graduate education at the University of Alberta, following which she trained in medicine at the University of Calgary. She completed a neurology residency and fellowships in movement disorders and neurogenetics at the University of British Columbia. In 1984, she joined the Faculty of Medicine at the University of Calgary, where she developed their movement disorders program and a neurogenetics clinic. She moved to the University of Alberta in 2010 as a professor of medicine and medical genetics, assuming the Tupin Research Chair in Neurology. She has many research interests, including the genetic basis for movement disorders. She is on the board of Parkinson Association and the Pan American Section Movement Disorders Society. Thanks for joining us, Dr. Suchowersky, and I will let you take it from here.
Great. Well, thank you very much for inviting me. And it's my pleasure today to talk to you a bit about Parkinson's disease and what we do when you first come to see a neurologist when you first get diagnosed. So first of all, just to remind everybody that the term Parkinsonism refers to a slowness or bradykinesia, rigidity or stiffness, and a tremor that's present primarily at rest. So these are the motor symptoms of Parkinsonism. Now there's many causes for Parkinsonism. Some infections, for example, COVID-19 can cause symptoms of Parkinsonism. Some of the drugs used in psychiatry can cause Parkinsonism. Vast strokes, variety of toxic substances can all cause Parkinson's disease. And then there's a group of what we call neurodegenerative disorders, or conditions that cause loss of nerve cells that can all produce their symptoms. So the first step in the diagnosis is to make sure that you don't have any of the other problems and that it truly is what we call true idiopathic Parkinson's disease. So currently we have a number of criteria which have been developed based on the clinical experience of many neurologists of what constitutes true Parkinson's disease. And those criteria are, for example, that Parkinson's disease always starts on one side of the body. It slowly progresses and eventually affects the other side of the body, but you can always tell which side it starts on because that's the more severely affected side. There are not a number of significant other symptoms. For example, there's no significant cognitive features initially, or no dementia. There's no loss of balance or falls early in the course of Parkinson's disease. So there's a number of positive symptoms as well as negative symptoms that we use to make a diagnosis of Parkinson's disease. There are other related disorders, and you may have heard of some of the terms such as Parkinson's plus or multisystem atrophy or progressive supranuclear palsy, which are other degenerative disorders that may mimic Parkinson's disease in the early stages. But Parkinson's disease remains a clinical diagnosis, so there's no specific test that we use to confirm the diagnosis of Parkinson's. Rather, we use good clinical criteria, and much of the time, the tests that we do, such as an MR of the brain or blood work, is to look for these other causes of Parkinsonism, which isn't Parkinson's disease. So once you have been diagnosed with Parkinson's disease, one question that comes up is, should you have genetic testing for Parkinson's? Currently, we feel that Parkinson's disease in about 10% of cases is due to a significant genetic cause. And in those individuals that have a strong family history, that means multiple family members with Parkinson's disease, or are young in onset, meaning under the age of 40 when they get symptoms of Parkinson's disease, there likely is a genetic cause, and we can do some genetic testing to determine if there is a specific gene that is causing the Parkinson's that's involved. In the majority of cases, though, we feel that genetics plays a very minor part in developing Parkinson's disease, and that the majority of the factors are probably environmental. And one of the biggest environmental factor that is thought to contribute to the development of Parkinson's disease is use of insecticides and pesticides, particularly paraquat. And so there's a lot of research going on into what environmental factors may result in an individual getting Parkinson's disease. And if there are questions at the end of the talk, I'm happy to go into more details about genetic testing. But in the majority of people, like I said, there's a minor genetic contribution, and the majority is environmental. So, and I should also mention that whether you have genetic testing or not, it doesn't alter the therapy that we would use in Parkinson's disease. Okay. So when an individual is diagnosed with PD, when should you start treatment? So things to consider are the level of disability. So for example, if you're having problem with walking and with balance, and you're having falls and there's a lot of stiffness and pain, then yes, absolutely, that is the time to start treatment. But in other people, it may be a little bit less severe. So things to consider, for example, is it the dominant side or your non-dominant side? So if it's your dominant side that's affected and you're having trouble with writing, your writing is very small. If you're having trouble shaving, if you're having trouble using your dominant hand, then probably it's a good time to start treatment. If it's your non-dominant side, for example, if you just have a little bit of decreased arm swing on the side that you don't use very much, for most of us it's our left hand, or if you drag your left foot a little bit but it doesn't interfere with gait or balance, then you may want to think about whether you should start treatment at that point or not. And the last point is whether it affects your employment. So for example, if you're working full time and you're finding that it impacts your employment, then treatment again should be considered. And recreational activities. So for example, I had a patient who was an avid golfer, and he told me that his handicap was going up because he couldn't swing the club as well and he couldn't golf as well. And so he started on treatment because that helped his golf game, it helped his social activities, he enjoyed life more. And so those are all things to consider. And this is something that can be discussed with your neurologist about whether treatment should be started. Now, the treatment is also personalized for you, and you may have heard about the topic about precision health or personalized medicine. And this is a case where we should talk to a patient about what treatment would be best for them based on the factors that we just discussed. So on the left side of the screen, you will see names of 3 drugs which are less effective. And on the right side of the screen are the drugs that are more effective. So let me start with the left side of the screen. Now, just to remind everybody that the motor symptoms of Parkinson's are due to loss of dopamine in the brain. So the chemical called dopamine is what the brain uses to provide movement. Okay. And so with loss of dopamine, the ultimate aim of, no matter which drug we use, the ultimate aim is to increase dopamine levels. So the MAO-B inhibitors, which there are 2 available for us, is rasagiline and selegiline. And what they do is they inhibit the enzyme that breaks down dopamine in the brain. So because you're not metabolizing dopamine, it will increase the levels of dopamine. The anticholinergics are drugs that decrease the level of a chemical called acetylcholine. So acetylcholine and dopamine are the 2 main chemicals in the brain. So acetylcholine is used for memory, dopamine is used for movement, but they sort of have to be balanced for the brain to work well. So because the dopamine level goes down, acetylcholine is relatively too high, and the anticholinergics decrease the level of acetylcholine. So both chemicals are brought back into balance. Okay. Amantadine is the 3rd drug, which acts similar to an anticholinergic and has some of the same properties. Now, these 3 categories of drugs, the MAO-B inhibitors and the anticholinergics and the amantadine, when they're used by themselves, will only help symptoms of Parkinson's disease for maybe 6 months, maybe a year, but then you will need to go on to something stronger. So they can be used initially, but then typically they're combined with other medications as the condition progresses and as the dopamine levels fall further. So next on the right-hand side, we'll start with the dopamine agonists. So you see there's 3 dopamine agonists listed there. Pramipexole and ropinirole are taken by mouth, and rotigotine is a patch that you put on your arm or on your abdomen. You put it on in the morning and you take it off at night when you go to bed. So dopamine agonists are medications that mimic the action of dopamine. So they mimic it. So they act, the brain thinks it's dopamine and it acts the same. The last medication is levodopa. So levodopa is converted into dopamine by the brain. So when you take levodopa, which is also called Sinemet or Prolopa, when you take it, it crosses into the brain and then the brain makes it into dopamine. So levodopa is basically the natural replacement for the brain of the chemical that it's missing. Now, one of the problems with levodopa is that your body and your liver is very good at converting levodopa to dopamine in the body itself before it gets to the brain. Now, when that happens, dopamine can't get into the brain. So whenever we give a person levodopa, we have to combine it with carbidopa or benserazide, because carbidopa and benserazide stop levodopa from getting converted to dopamine in the body. So the levodopa stays at levodopa It then crosses into the brain. There's something called the blood-brain barrier. So it crosses into the brain through the blood-brain barrier, and then the brain can convert it into dopamine and use it. So that's why you'll always see the two names when you get your prescription. You'll always see the two names, levodopa carbidopa or levodopa benserazide, together to get more of this chemical into the brain so it can be used more effectively. These preparations are available as short-acting or long-acting. Now, in early Parkinson's, when you first start on the medication, the brain, once it gets hold of the dopamine, can actually store it and use it quite physiologically. So you don't need the long-acting preparation. The short-acting preparation you can take 3 times a day, and it gets into the brain stores it and uses it. So generally, the levodopa works quite well, even though you're only taking it a couple of times a day. Okay. Now, so those are all the choices we have. And generally, when you first start treatment, you would only start with one of those medications. As the disorder progresses, then we combine all of those medications that you see listed there to give a better effect. But we're only going to talk about which medication to start with. So that depends, first of all, on your age. And if you're older, I would not use an anticholinergic because, remember, it decreases the level of the memory chemical acetylcholine. So in older people, and those of us that are a bit older already have a little bit of problems with short-term memory, our memory will get worse. Okay, so anticholinergics would not be used for people with that are older, but sometimes we will use them in young patients, particularly if they have primarily a tremor and not slowness or stiffness, and then it can work reasonably well for some time. Secondly, the level of disability, which we talked about already, and that if there's quite a lot of stiffness and slowness, then I would say levodopa is the best drug because it is the most effective treatment. It is the natural replacement for dopamine. If you have less significant symptoms, that you might want to choose one of the other choices there. And next thing is to consider the side effects. And I'm going to go into more detail about the side effects that we see with these medications. And lastly, cost can be an issue. So when we look at, I'm just going to go back to this slide. So there are some medications that are cheaper than others. So for example, selegiline is generic, very cheap drug. It's an old drug. Anticholinergics, amantadine are all generic, old drugs, very inexpensive. Rasagiline is a bit more expensive. It's a newer drug. Rotigotine is probably the most expensive drug currently because it is the newest drug and it has not gone into the generic formulation yet. So you may want to check with your insurance company whether, when you're decide on which drug is best for you, whether it is covered, first of all, and how much is covered, because cost can be an issue in choosing these medications. And many of them work. For example, selegiline and rasagiline work just as well. Selegiline may have a little bit more side effects because it can cause some hyperactivity, but in patients who have apathy with their Parkinson's or fatigue, selegiline may be a better choice than rasagiline. So that comes back to that sort of personalization of treatment of what are your more significant symptoms and which one you choose. Okay. Now we're going to go to side effects, and this is very important discussion. So many of the or a number of the medications, particularly the dopamine agonists and levodopa, do cause nausea and can cause a significant amount of nausea in people when they first start them. So I always start both levodopa and dopamine agonists at a low dose. So you start them at a tiny dose. You ask people to take them with meals, breakfast, lunch, supper. Not only is that an easy way to remember it, but it decreases the risk of nausea. So if you take them on a full stomach and then you very gradually increase them over weeks to what we think would be a therapeutic dose, the lower therapeutic dose. So if it's increased very gradually, that you can avoid the nausea. Some people still have nausea in spite of that. And then there are several medications that we can prescribe, one of which I'm blanking on the name right now. There are several medications that we can use, some of them that we use for cancer treatment for nausea, like ondansetron. The one medication that you absolutely should avoid is called metoclopramide or Maxiran. So that's a very commonly, Maxiran or metoclopramide are very commonly used for treatment of nausea in the hospital. It's used for migraine nausea, for post-operative nausea, and it worsens Parkinson's. So please, when you make sure that when you do go into hospital, that the physicians that are looking after you know to avoid Maxiran or metoclopramide. And what we have, our clinic has, is a little sheet that we can give to you when we know you're going to hospital that tells the hospital which medication should be avoided in Parkinson's disease. Also, if you're on Sinemet and you get nauseated, Prolopa, which has benserazide instead of carbidopa, is good for nausea in some people. So the Prolopa formulation may have less side effects than the Sinemet preparation. The second thing to be aware of is somnolence or drowsiness. So these medications, particularly dopamine agonists and levodopa again, can cause drowsiness, and it can even cause sleep attacks. So we've had cases where somebody is driving and falls asleep at the wheel. So when you're starting them, you need to be very careful. And in fact, it's recommended that you avoid driving for the first few weeks when you're starting these medications, just to make sure that you don't get sleep attacks or daytime drowsiness episodes. And if you do, as you saw from the list, there are a number of medications. So if you get side effects from one, we have other options to switch to that hopefully you won't have side effects from. But daytime drowsiness and sleep attacks are not uncommon, and you need to be very careful with those. The third thing is that the medications will lower blood pressure. And that's called postural hypotension. What that means is that when you stand up, you feel dizzy because your blood pressure drops. So if you feel dizzy when you stand up, please sit down or lie down so that you don't faint, because occasionally there are cases of fainting. And the blood pressure, if you have a home blood pressure machine, it's good to measure your blood pressure lying and standing the way we do in clinic. The other point is that we've had lots of cases where a person has hypertension, high blood pressure, before they get Parkinson's. And when they get Parkinson's, because of the medications that we use, the blood pressure pills need to be decreased or sometimes even completely stopped, because the blood pressure, it becomes lower, so you don't need the blood pressure medications. And the other way of treating this is to make sure that you get enough fluid with salt, because salt is what keeps your blood pressure up. So again, another thing to watch for. Another thing that's not on the list, but that I've seen in a number of patients, is leg swelling. And some of the medications will cause leg swelling, particularly if you're on a a drug for arthritis. If you're on an anti-inflammatory, you can see leg swelling. So not a serious side effect, but just something to be aware of. The next thing I'd like to talk about is impulse control disorders. And we know that with the dopamine agonists, that's with pramipexole, ropinirole, rotigotine, that people can develop impulse control disorders, which means that something that they may have enjoyed doing socially, they can't stop doing. So the most common example of this is gambling. So there are patients that like going to the casino maybe once a month, lose $100, go to Las Vegas once a year, lose $200. But you know, I mean, it's can be a pleasurable activity, and that they go on to one of these medications and they can't stop gambling. So they're gambling every day, they're going to the casino, they're gambling online. And we have had patients in the past that have lost large amounts of money because of this impulsive gambling that they can't control going on these medications. Compulsive shopping occurs, compulsive playing video games, sometimes compulsive eating, compulsive collecting things. And so this is all something that we recognize. And although it can happen out of the blue, typically it's some activity that you enjoy doing, but then just you become obsessed with it and you can't stop doing it. So this is something that, at least in our clinic, we always ask our patients every time we see them if this is occurring. And sometimes the person that is on this medication isn't aware of it. And it's very important for the caregiver or spouse to be aware of it and to keep monitoring this. And we have had some situations where the spouse has had to take over managing the accounts to help with this. And of course, if we know this is happening, we would change the medication to another one that doesn't have this side effect. Lastly, I'd like to say that there is no evidence of levodopa increasing or worsening Parkinson's disease or causing side effects out of keeping with what we expect with the normal progression of PD. So there's still stuff on the web that says how levodopa is toxic. Levodopa is not toxic. It is the natural replacement for, in Parkinson's disease, natural replacement for dopamine. And in fact, there are several studies that have suggested that if you start levodopa a little bit earlier, that it may even be neuroprotective, that it may even help those neurons because they don't need to produce as much dopamine. So please, if you feel that there is a disability, please start levodopa or another medication, which is best for you, but don't delay treatment because there is no evidence that delaying treatment slows down progression of Parkinson's. And in fact, it's quite the opposite, that if you delay treatment, then you miss the years where the treatment might work the best and help you the most. Okay. The other thing that I should just mention here is that if you remember at the beginning of the talk, I was saying that we use medication to help us decide whether it's true Parkinson's or not. So the other use for levodopa is if we're not sure whether this is true Parkinson's disease or another disorder. In Parkinson's disease, people with Parkinson's will always respond to levodopa. So in Parkinson's disease, if you start on a little bit of levodopa, you should see a good benefit. And that's one of the ways that we can confirm that it is true Parkinson's disease, because the other disorders that I mentioned won't have as good an effect, or sometimes even no effect from levodopa. Okay. Now, Parkinson's is not just a motor problem. There's a lot of non-motor symptoms that happen both before the motor symptoms of Parkinson's and during motor Parkinson's disease. So the first of these is the gastrointestinal tract. So in Parkinson's, the gut slows down. And initially, the major symptom is constipation. And the constipation can start several years before the motor symptoms of Parkinson's. So if you talk to many people who are diagnosed with Parkinson's, they'll say, oh yes, 5 years ago, I noticed that I started getting constipation. So that is what we call a prodromal symptom of PD, but you do need to keep on top of that. And if the gut isn't moving the way it should, then the medications don't work as well. They don't get absorbed as well. So that it is important to make sure that you treat the constipation and stay on top of it, whether it's extra fluid, prunes, bran, whatever you need. And later we used a different variety of treatments for the constipation if it gets severe. The second problem is depression and anxiety. So in people who have never had any problems with depression or anxiety when they were teenagers or young adults, about 5 years or so before getting motor symptoms of Parkinson's, they can start to get depression and anxiety. So this is another prodromal symptom of Parkinson's. Now, depression and anxiety can be treated either with counseling or with medications, and we have very good medications to use for depression and anxiety. In our clinic, we have a very good psychiatrist, Dr. Parada, that works with us, that I'm sure many of you know. That helps us in this treatment. And one point is that if you are on an SSRI, which is one of the common drugs for depression and anxiety, if you start on an MAO-B inhibitor, that is selegiline or rasagiline, there can be an interaction between those two drugs, which causes side effects. And it causes something called serotonin syndrome, which causes sort of hyperactivity and sweating. And so if your physician starts you on an SSRI and the neurologist starts you on a rasagiline or selegiline, you will get a note from the pharmacy saying you shouldn't go on these medications. Now, it is something that you need to discuss with the neurologist, because while there is this side effect and this interaction, it is quite rare, and the potential benefits may still outweigh the potential side effects. So that needs discussion. The third prodromal symptom that begins before onset of motor symptoms of Parkinson's is disrupted sleep, as well as acting out your dreams. And acting out your dreams is called REM sleep behavior disorder. So normally we're paralyzed when we dream, right? So we don't move. But in Parkinson's, this that system doesn't work as well. And so sometimes you may, when you're dreaming, thrash in bed, kick and punch. And so that's called REM sleep behavior disorder. So that, again, is something that you can discuss with your treating physicians if that happens. Now that we already talked about some of the other non-motor symptoms, such as low blood pressure when you stand up, which can be treated quite easily. Sexual function may decrease. You may lose your sense of smell and taste, and those all can be discussed. And for some of them, they can't be treated. Others can be treated. The only other thing I'd like to mention there is that what we're finding more and more is that apathy and fatigue can be part of the manifestations of PD as well. Apathy, we are not able to treat. There are no medications for that. But for fatigue, we may use selegiline, for example, which I already mentioned, or there are other medications specifically used for fatigue that we may add to the treatment regime. Now, alternative treatments. Exercise, exercise, exercise. We want everybody exercising at least an hour every other day. And it doesn't seem to matter what exercise you do. If you want to go for a good brisk walk for an hour every other day, if you want to do some cardio with weights, if you want to do Pilates, if you want to play pickleball, which seems to be very popular now, it doesn't seem to matter what you do, but you do need to exercise regularly. We know that if in people who exercise regularly their whole lives, their risk of getting Parkinson's is lower than those that don't exercise regularly. And we think that exercising regularly may even slow down progression of Parkinson's. So I know Parkinson Alberta has a lot of exercise programs. There's a lot online. I know with COVID it's difficult, but there is a lot online that you can, exercises that you can do. Next, as PD advances and you don't have the ability to move as well or maybe exercise as well, osteoporosis can occur. And so in Alberta, actually, it is suggested for all of us to take vitamin D. My family doctor told me to take 2,000 a day. But that's something that you should discuss with your family doctor. And generally 1 to 2,000 a day of vitamin D is recommended, along possibly with some calcium to decrease the risk of osteoporosis. The other thing is to start B vitamin supplementation. When you are on levodopa, levodopa is metabolized by the body and the brain. And levodopa uses B vitamins as cofactors to be metabolized. So you use up more B vitamins when you're on levodopa than you would otherwise. So people who are started on levodopa should be started on B vitamin supplements to decrease the risk of other complications. And one of the complications in people who have been on levodopa for a long time is damage to the peripheral nerves due to the damage to the peripheral nerves in the arms and legs. So I would suggest that if you are starting levodopa, that you start on a B vitamin supplement, and just a general B vitamin supplement is fine. Lastly, of course, Parkinson Alberta, other societies are very important in supporting individuals and families who are affected by Parkinson's disease, both through counseling, support groups, exercise, information. So I always encourage everybody to join, of course, Parkinson Alberta, but to access educational programs in all societies that deal with people with Parkinson's. Now, I don't know if you know, I don't know if the information has been sent out, but the World Parkinson's Congress is coming up in May. And that is a large international meeting of everyone involved, both people with Parkinson's, families with Parkinson's, us as clinicians and researchers that all work in Parkinson's disease. And it'll be a 3-day program of all sorts of information on what's going on in Parkinson's disease, both in research and in treatment. So I encourage you all to go onto the website of the World Parkinson's Congress and sign up for what looks like to be a very promising educational activity. So I'll stop there and I'll open up the floor to questions.
Okay, perfect. We have quite a few questions that have been popping up here. All right, I'll start off with something that you just talked about. I'm assuming this might be something to talk to your family doctor about, but are there specific dosages of the other vitamins that would be good for people with Parkinson's?
Yeah, there's nothing about other vitamins. In fact, we did studies in vitamin E, creatine, other supplements, and there are no other supplements that have been shown to be needed or helpful in Parkinson's disease. So the only two that are recommended right now are the D and the B vitamins. but specifically, but there has been work done in some of the other supplements and vitamins, and nothing else seems to pop up.
Okay, very cool. And it's best to talk to your doctor about how much of those to take specifically for you.
Well, vitamin D, like I said, I think the general recommendation now is 1 to 2,000 milligram units a day. Calcium is a little bit different because there's different recommendations for calcium depending whether you're male or female, depending on your age. So calcium is something that you should talk to your family doctor about. For B vitamins, we don't know the specific dosage. So actually that research was done by us, by my group, on B vitamins. So we know that B vitamins are used up, but we haven't done the studies yet to look at what the correct dosage is to supplement. So all I can say is just a regular B vitamin supplement is fine.
Okay, that makes sense. The next one is, where does entacapone or Compton fall? Into which of your categories of medication, I believe is the question.
Yeah, so we wouldn't, as somebody that is just starting on Parkinson's, we would not start them on entacapone. So entacapone doesn't do anything by itself.
Okay.
It is added to levodopa because it does if you remember, I talked about levodopa needs to be combined with carbidopa or carbidopa or benserazide to prevent its metabolism in the body. There's another enzyme called COMT or COMT. So there's a little bit of COMT left that metabolizes levodopa, and entacapone inhibits COMT. So if you use levodopa with carbidopa and with entacapone, that more can get into the brain. But we use so like I said, it has to be used with levodopa, but you really don't need to use it unless you have a bit more advanced symptoms, because we want to get that extra little bit into the brain. So generally, Comtan is added later on in the treatment.
Okay, not so much for the newly diagnosed.
That's right. That's right.
Okay, makes sense. Someone was wondering, if you don't have the side effects you had been mentioning early on when taking the medication, can they develop later into the medication use?
So generally, things like nausea and sleep attacks and the gambling, obsessive compulsive symptoms will develop fairly early on when you're starting the medication. If you don't have it initially, chances are you're not going to develop it later. The low blood pressure does develop later as the doses increase. It will drop the blood pressure more and more. So you might not have problems with low blood pressure initially when you're first starting the drug, but then when the doses go up, they will develop later on. So the low blood pressure needs to be monitored the whole time. And that's why in our clinic, we always take blood pressures lying on and standing on everyone when they come in to see us.
That makes sense. Thank you. All right. Here is another question. Do you see worse progression if you choose to delay the start of medication? If there is, and also a follow-up, is there a typical time for people to start medication from the time of diagnosis? Like, what would that be if there's one?
So first of all, it really depends on your symptoms and how much they bother you. And from the time of diagnosis, that really depends on who you saw and when the diagnosis was made, because some people, they notice a little bit of tremor, a little bit of slowness and stiffness, they get in to see us right away. And so the diagnosis is very early. But there's other people that think it's just normal aging and don't come in to see us for quite a while. So you can't talk about time of diagnosis, because that really varies on how soon you get to see a neurologist to make that diagnosis. And some people, particularly if they live in remote areas, they may not come in or want to come in to see us for quite until they're quite significantly affected. Now, if you delay treatment, there is really no evidence that the progression will be faster or slower. But the problem is that what they did, there was one study where they started people on levodopa right away as soon as they had mild symptoms, and the other group that delayed by a few years. And when you look at the people that started treatment right away, they just did really well and kept doing well for quite a while. And then the people that delayed treatment just seem to never really catch up and do as well. So I think that I don't think it's the overall progression. It's just, like I said, if the first 5 years you're going to get good benefit from the medications and do really well, why wait 2 or 3 years and then you only have 2 good years or 3 years to do well? Is that clear?
Yeah, that definitely makes sense. And as you said earlier, starting the medication sooner doesn't make Parkinson's progress any faster.
No.
So,
and in fact, it may make it progress slower. That hasn't been proven, but some people think that.
Right. So, getting as many good years as you can.
That's right.
Sounds good to me. All right, here we go. If the tremors are not controlled by or at all by levodopa, what action could be used in addition?
So if the person is young, we could add a anticholinergic or amantadine. If they're older, we would add a dopamine agonist. So we would use combination therapy. And sometimes pramipexole can help with tremor. Sometimes there's other medications. So in some people, the tremor can be very bothersome and doesn't respond well to levodopa. And that is a difficult tremor to treat. So there are a number of other medications that we can try. So it's trial and error. There are a number of medications. And then finally, if the tremor is really not controlled by medication, then we would go to deep brain stimulation due to the surgical therapy for Parkinson's disease. And I think people are starting to do deep brain stimulation a bit earlier. We're not waiting till the disease is really advanced. That there are several different ways to do deep brain stimulation now. And certainly I would not hesitate to refer someone to the surgical program if we really couldn't get on top of the tremor, because that is very uncomfortable and disabling.
Yeah, absolutely. And is there kind of like an age limit at the top end of how old you can be to be eligible for that surgery?
Yes, generally it's 70 years old. So after the age of 70, we know that, the brain has less resilience. And so by doing the surgery that we can cause some damage, some permanent damage to the brain and affect memory. Now there are new techniques coming out with the gamma knife and radio frequency. So there are newer surgical techniques that we may be able to use in people that are older with the rest tremor now. Okay. And Dr. Sankar has been trained to do that. So we are, like I said, there's a different operation in people that are over 70 that we can do now.
That's excellent news. Okay, there is a question about how people are being exposed to insecticides, and pesticides. Is it the industrial level of exposure or just from eating the fruits and vegetables? Is that how the exposure is happening? What does the research say about that?
Yeah, there's no definitive research about that. Like I said, the exposures, I don't think it's used in Canada, but in some countries is thought to be a contributing factor. There's no evidence that eating fresh fruit and vegetables, and of course you should wash them, but there is no evidence that it contributes to development of Parkinson's right now. The research on the environmental exposure is very hard to do, because if it's something that happened, because we think right now that Parkinson's starts 20 years or so before we get motor symptoms. And so how can you remember what happened or what you were exposed to 20 years ago, right, when you get diagnosed with PD? So this type of research is quite challenging. What they're trying to do is to follow the people who get the sleep problems, maybe anxiety and depression, who they think are going to develop Parkinson's in the future, and follow them that way to try and get a better handle on it. But like I said, the environmental exposure is really very hard to identify. We know that concussions increase your risk of getting Parkinson's. Not the type that Muhammad Ali had, which was different. That was due to multiple head injuries. This is just normal concussions, but they increase the risk of Parkinson's. Like I said, living on a farm, presumably due to insecticide exposure. If you grow up on a farm, your risk of getting Parkinson's is higher than if you live in the city in Canada. If you drink coffee, your risk is less. If you smoke, smoke cigarettes, your risk is less. We don't know why that is. So there are some sort of tantalizing factors, but we really don't know enough about them.
Okay, that is fair enough. It's a challenging thing to research, it sounds like. All right, I think we have 2 more questions if you have time for that.
Sure.
Perfect. Okay, so this one's a little bit specific. I'm going to try and generalize. So someone was diagnosed about a year ago, and they've recently gone down on their Cinement and pretty much are off of it now, and they're still doing okay. And they're just wondering, they're still on Prolopa, but they're feeling really good. And they're wondering if maybe—
What do you mean? Prolopa and Cinement are basically the same stuff.
Okay.
So if they're on Prolopa, that's being on Cinement. So it sounds like somebody switched them from Cinement to Prolopa because of side effects. But Prolopa is Cinement. It's just a slightly different combination of chemicals. That's all.
All right. Well, that is great information. Perfect. Thank you. And then the last one here is it important that the exercise be a full hour all at one time, or can it be broken down into 30-minute chunks at different times during the day?
Yeah, that's a good question. And I would say, yes, it doesn't matter if you do it all at once, if you do half an hour every day, if you do an hour every day, if you do, some people think that if you do it, we just don't know. And that hasn't been really looked at. So I think the more you exercise, the better. There was a news item very recently about that. If you exercise in the morning, your memory's worse. I don't know if you all saw that. That was on CTV a couple of days ago. So I don't know what that means, but generally, it doesn't matter. And I think it was from just the general exercise literature, it appears that exercising several times a day is better than doing it in one chunk. So if you go for a walk 2 or 3 times a day, or in the morning you do your cardio, in the afternoon you do Pilates or yoga or something. So it seems that exercising in shorter periods, but more often during the day in general, is better. But that's not specific to Parkinson's. That's just a general observation.
Right. That makes sense. All right. Thank you so much. We really appreciate you being able to join us today, and thank you for taking time out of your busy schedule. Just a reminder, our next scheduled webinar will be on April 7th, and it will be just a Parkinson's 101 presentation. So if you have questions, come on April 7th at 10 a.m. And thank you again, Dr. Suchowersky.
Thank you. My pleasure.
Bye.
Bye-bye.